Hello, everybody. I hope everybody can hear me. Welcome to this webinar. This time, the webinar is really exciting. Out of this reason, I am sitting in Australia, and Andrea and his brother, who is still in operation as far as I hear, sitting in Italy, and our help team from the headquarters of TRI is in Switzerland. So very warm welcome from my side from down under in the headquarters TRI Australia. Today's topic with Andrea Agnini and Alessandro Agnini. Hopefully Alessandro Agnini will come and join us at the end of the presentation with a really great topic. The digital revolution 2.0 is the topic for today. And I think Andrea and his brother, they're going to show us really interesting stuff. But before I pass the words to the two Agnini brothers, I would like to explain a little bit more detailed also the TRI revolution, the matrix implant. And the matrix implant is the digital revolution of TRI. And the matrix implant, you can see it here in how it looks. And it is an implant where we eliminate the need of an abutment. You don't need a cementation anymore. And you have, as a dental technician spoken, as I am, you have no limits. I think everybody knows me. I'm Holger Kast. I'm the head of training education at TRI. I forgot to mention this, and we have also certain rules in the webinars as usual. If you have questions at the end, we have a little question answering session, and every question you have, please write it in the chat or in the question field, and I will pass them later on to the Agnini brothers. So back to the implant, the matrix implant, no abutment, no cementation. That means we have a revolutionary implant designed already now 3.5 years in the market. And my question to you is, do you like cementation? Do you like abutments? And that's why I added this picture here. Because this is what we do in our days. As a dental technician, I always ask, hey, doctors, do you like cementation or do you do screw retain? When you ask them, it's always like, yeah, we do screw retain, but we might sometimes forget that a tie base is always needed. That means a dental technician has always to cement a tie base underneath a monolithic or digital created crown. And so when you see this is when you cement on a tie base and a crown, and you see this overfloating cement. The dental technician cleans this in its best way, but there's still some cement gap to see, and sometimes we in TRI get failed implants or failed situations in a patient's mouth. And then when you see this connection here, you can think how much bacteria are involved in the cementation, which is very deep in the tissue. And that's why we had this idea of the matrix. And how is this possible? I will explain you a little bit later. The next slide just shows you that there's only a few studies in this moment out what happens when you have screw retained implants with a tie base. So the tie base is screw retained, and you can see here in this study from the University in Zurich that this is the implant, and this in the middle here, that line is the tie base, and this is actually the cement gap cleaned by a dental technician, and on the top here you can see the crown. And what this study is showing is a 5 years aging time under temperature, normal temperature, a 5 years aging time with hydropulse tests, and this is how that looks after 5 years. You can see clearly bigger gaps between the cementation and so on. If we take a closer look to this, it looks like this, and this is what patients have in their mouth when you use tie bases, which is the way to combine actually this digital based prosthetic work with the existing implant systems. because you see here, this is the old world. This is all implant systems we have in the market, like hexagon connections, octa, Morse taper connection, deep connections. These are created designs of really well functional implant connections, but to adapt them to the new world, which we are talking about today, the digital world. It is tricky because these connections are not made for zirconia. They are not made for this material, for example. They are also not made for CAD/CAM based, that means milling based prosthetics, and they are not made for 3D printing. And so that's why we had many years ago the idea, why not changing this interface of an implant towards a CAD/CAM based prosthetic. And that's how this looks like. You can see here, any of you, maybe there's also listening some dental technician, any of you is in our days able to mill in a very high perfection this inner connection of the crown into this matrix connection. This is made for CAD/CAM and digital workflows. How is this possible? So we developed not only the perfect connection for ceramics and not only the perfect milling design for as an implant, we also designed and created the so-called milling strategies. And I want to show you this on this slide. You can see here on the left side the so-called STL files. The STL file is created when you design a crown in exocut or tree shape. You have this STL file, and you can see here, this is all little triangles, and this is what your milling machine is milling out in a more or less accurate way. But for a connection milled in zirconia or also in titanium, what is possible, or in PMMA, you have to have a perfect fitting connection. And therefore, TRI developed so-called milling strategies. And you can see here, these yellow lines, this shows what the drill, the milling path is doing. So every 2 micron, the drill is circulating in the milling of a matrix connection. It circulates in 2 micron distance. And this is the so-called strategies, which we tell your milling machine how it has to mill. And we add these milling strategies into your CAM software. And after this is in your CAM software, your machine is milling the perfect matrix connection. You can see that on this slide. This is how the connection comes out of the milling out of the milling machine before sintering, and due to sintering, it shrinks even 20%. And then this is the surface you create, and you have ready for a final restoration, for a final zirconia crown, screw retained without an abutment, without the need of cementation at tie base into the implant. That's just the last picture. I forgot here the name. This is a picture from Joel Deller's work, a full arch case on the matrix. And you can see here this perfect fit on the implant analog in this moment. But now I think it's time to pass the word to Andrea. And hello, Andrea.
Hi, Holger.
You are
great
going
to
show
hear you
us
as well.
Yeah, okay. We can hear us very well, even we are totally on the other side of the world. That's very perfect.
Yeah.
That's
the power of digital, no? We have to discuss about digital solution. I mean, that's the best digital solution that we can speak about. You are in Sydney, I'm here in Modena. We have like more than 100 participants from all over the world. Valentina is in Zurich, so that's digital dentistry.
That's digital, not dentistry in this moment, but digital dentistry. I think we have here really the perfect match with our digital implant. And you guys from Modena, we have really also this digital workflow since many years, and I'm really excited to pass the word to you. And before I do that, I just want to remind you or tell you that we have also planned a course, and I think Andrea will tell a little bit something about it, and I, at the end of your presentation, will give you a very special offer actually for the course we are planning this year in Modena with live surgery and so on. But at the end of your presentation, we will share a special rate for this course for all participants which are here in the webinar participating today. So go ahead, please switch to your computer, Andrea, and
yes,
wait.
You
Okay.
should stop sharing. Okay, so
Yeah.
if you stop sharing, then you can see me. You should see
Yes.
my computer right now, right?
Perfect. Let's go ahead.
Okay, great.
Thank
So thank you, Olga, for the kind invitation, and of course, thanks to Trimplan and Valentina, which is behind the scenes, like the big, not brother, but sisters in this case, because she's double checking everything that you are doing. And of course, it's a great pleasure for me and my brother as well. My brother is in the other room, which is finalizing a surgery. Hopefully, he can join later, because we had a slow start this morning, so that's why we are like try to get back on time. And as once again, it's a great pleasure like doing something and collaborating with Trimplant, because we are known as, like, let's say, some of the innovators of digital dentistry, some of the pioneers of it. And when a few years ago, Tobias and Olga came to our clinic and discussed about this project with us, we engaged immediately from the very beginning, and we were very excited because we think that no matter what the fact that the implant was a new concept and everything, we need to work a lot and work hard to make it work. But the thing is that the innovation, the idea that was behind was absolutely great. And this is exactly what really excited us back then. And it is great to see how big steps have been done, how many steps they have done in the last years, and how many achievement we were able together with them to obtain in this specific field of dentistry. Because now we're talking about the digital implant revolution, and then the matrix is absolutely a revolution. We can really say that it's a disruptive technology that can change, and that has already changed the way that we are like working in our implant prosthetic department. We discussed about all of these changes that we have done in our book together with Christian Kochman as well. Actually, this book, it was very nice, always talking about the partnership that we have with the TRI. We add like one chapter in where we are discussing in details about the potentials and about how to utilize clinically this kind of product. And of course, today I will discuss about it. And it was very nice to present officially the English version of the book at the recent IDS, in where I was hosted by the very crowded Matrix booth, because there were like in between like the implant manufacturing booth. Matrix was probably the only one at IDS that was offering something for real new, because really the concept is completely disruptive. The concept from the Matrix is completely changing the way we were used to think about implant prosthetic workflow. Because starting the presentation, I mean, when we are talking about a revolution should like really change what was before, and should be cost effective as well. We should immediately embrace the benefits of this revolution. We should not lose time. We should actually gain time, and time in our world means money. So we need to keep the quality of our restoration at the standard of care, which is great for our patient, because at the very end of all the discussion, the patient is always in the center, is always the fulcrum of our treatment. Everything that we are doing it for the patient. And so we are doing to enhance the quality of the life of the patient, to enhance the predictability of the restoration that we are doing for our patient. And why Matrix implant is a revolution? Because if we go back just with one slide on the classic digital implant prosthetic workflow, we see that also with the TRI before the matrix, we were working and we were doing a good implant prosthetic restoration in where we had like a dedicated scan body, we had a good CAD software, we had a very accurate titanium base and a very well designed titanium base that was giving us the opportunity to offer to our patients smart, simple, and predictable workflows while we were doing while we were doing implant prosthesis in their mouth. And of course, technology is always a combination of different factors. One of the factors is the intraoral scanning technology, which of course has been, and right now is a reality and has been a disruptive technology that completely changed the way we are not only working on patient, but also the way we are communicating with the patient. But if we are focusing on prosthetic workflow, the combination between the intraoral scanning technology and the new material, the evolution that the materials, especially talking about the monolithic technology material, had in the latest years has been incredible and gave us the opportunity to really fill up all the different dots and creating a workflow which was very fast because we were able to take an impression and then they meet the appointment after we were able to finalize and to deliver the final restoration. So this combination was completely disruptive in the way we were working because we passed from, like, let's say, the traditional workflow which was made out of 15 steps in where all the quality control steps were always after that the patient left the chair because we were taking the impression need to be poured, and then only when the lab was producing the master model, we were seeing if we were able to be accurate or not if we were able to be accurate or not with our traditional impression. So we had 15 steps of working to do one single crown. Thanks to the combination of the intraoral scanning technology, the CAD technology, the CAM and the CAM technology, we were able, combining it with the monolithic material, to bring these 15 steps down to 5, having always the quality control step at the very beginning of the workflow, because we take the impression, we double check while the patient is still sitting in our chair if the scan body has been detected properly, if the bite registration has been done accurately. We can double check every single parameter that we want to have at the right spot, and then we send everything to production. So the quality control is at the very beginning, and we are decreasing the steps. So this was the advantages that the traditional full digital workflow combined with the implant with the digital impression and monolithic material was offering us, until the matrix came in the ballgame, because absolutely this changed once again things, because we see, and we were and I will show you how many steps we need to do to finalize a crown on implant in a digital workflow. We have 7 steps. These are the key points. We have the intraoral scanning. That is the very first step, because every digital workflow starts with the digital impression. Then we had the choice of the choice of the scan body, which is another important aspect, and we are gonna deep dive in it later on the day. Then, of course, we had that the CAD software, the design of the restoration. Restoration must be produced, so we have a milling phase. And we will see that now this milling phase is switching also with the 3D printing phase, and Matrix and 3RI created a very nice workflow in where we can scan and immediately print the provisional restoration in simply 1 hour. If we were in an anterior region, you see that we needed to 3D print a master model in where to do the final ceramic layering to enhance the aesthetic characteristic of the restoration. And then we add the last two steps, so the cementing of the T-base into the final crown. So you see that we had like mainly 7 steps if we want to work in an anterior area. So model workflow, model need workflow. If we were in a posterior area in where we just need a monolithic workflow, we just need to erase this step of like producing a master model, and we need 2 steps to do in order to fulfill a accurate digital workflow. And you see that every steps that we are doing, like in everything, in every other thing that we are doing in dentistry, the more steps we have, the more inaccuracies we probably have, because every steps, even if it is done by the most prepared dental technician, the most trained clinician in taking digital impression, has an intrinsic inaccuracy that is been determined in the iOS in 10 microns, scan body 5 microns, milling 10 microns, 3D printing 30 microns, and T-base cementation as well at a 35 microns of potential inaccuracies that all of them can be add on the overall workflow, and we have like an accurate restoration, which has, let's say, 90 microns potential inaccuracies. But we were talking about T-bases, right? And also Olger showed you that T-bases might have some problems, but we should not forget that T-bases gave us the opportunity to complete a full digital workflow before the matrix implant came into the ballgame, because the T-bases still today represent the 68% of all the abutments which are used in the market, because they have, of course, advantages. They increase the mechanical stability for posterior area. They simplifying the CAD/CAM procedure due to the standardized component. If like the T-base that TRI was used to produce had a nice shape, a nice design, you were able also, you see from the pink color, to mimic the components below the soft tissue. But as Olger brilliantly explained to you, besides the benefits that T-bases undoubtedly are offering, there are also some limitations that should not be underestimated, because this is a very nice article from the Journal of Prosthodontics of 2020, in where we are like, they have been evaluated the gaps between the cementation interface of the T-base and the crown. And it has been seen that 1/3 of the studied CAD/CAM crowns, they were presenting gaps. And we were seeing as well that the main bending moment of restored titanium abutments was significantly higher compared to all tested ceramic restoration. So this means that we have problems also with T-base, especially on a long run period. I don't want to have like problems in design, because there was also a limited design flexibility issue. I don't want to have aesthetic disadvantages because the T-base was not pink or anodized, and we had like a titanium abutment and we have an aesthetic disadvantages. I don't want to have higher cost because I'm adding one piece of the puzzle in my prosthetic and armamentarium, and so I need to pay for these components. But most importantly, I don't want to have, especially on a long run period, any risk of inflammation or the bonding due to the cementation, because that's the most important piece of the puzzle that we need to think about it. We don't want to have like peri-implant inflammation of the perioral mucosa or the peri-implant mucosa. I don't want to have the bonding or like a slight the bonding in where like we have this gap in where bacteria gets inside, and then on the long run they will like jeopardize my implant prosthetic restoration. So why the TRI with the matrix implant is a disruptive technology? It's the first implant which is being thought without the use of any abutment. So we don't have any abutment, which means that we don't have any cement, which this is a great idea. And we are living in an era in where we are trying to remove all the interfaces. If you think about why monolithic materials came into the game, because the layering ceramic were over time chipping. We were seeing delamination, we were seeing chippings. And so that's the reason why the companies that are producing the materials created the monolithic material, which is a one-piece material. So there is no interface. There is not the interface between the zirconia and the ceramics. And so we don't have any possible complication in that interface. If you think about this concept is the same concept that the matrix implant has, is reducing the interfaces, is removing the abutment, and so we don't have the problem of the cement. We don't have the problem of the design of the tie base. That's the concept, and that's unique in the implant field. So that's very important. And nonetheless, it's important because if we are reducing the interfaces, we are also reducing the steps. And as I told you before, each step has a potential mistakes inside. So if you are reducing the steps, we are decreasing the potential mistake by 73%, because we don't need the model anymore, we don't need the tie bases anymore, we don't need to cement the tie base into the final restoration anymore. And so we are decreasing the potential mistake from 90 microns down to 25 microns. So remember the first graphic that I showed you in the very first slide. We should increase the quality of what we are doing, or at least maintain the same kind of quality while we are adding a new thing in our workflow. So while we are adding a great idea, we need to keep the quality high, and like this we are increasing the quality. And also the time cost, and especially the cost in this case, is increasing because we are reducing the interfaces we don't need to get and to pay for any tie base anymore. So that's another advantage. And versatility, in my opinion, is another keyword. Versatility is another keyword because we need to have like products that work no matter for everyone. Because maybe I prefer to work with tissue level implant. You guys that are listening prefer to work with bone level implant. Or more probably, there are some clinical scenarios which are more ideal for tissue level implant, and other anatomical scenario which are more ideal for bone level implant. So they came out also not only with one implant, but two implants, which one is tissue level and one is bone level, that they both work very well and offer us versatility of clinical use, which is another important aspect. And this has been probably the very first matrix implant that we have placed, I think, more than 2 years ago right now. And you see that straightforward case, 2 implants in the posterior region. Here you see a few snapshots of the restoration. You see that we have the healing colors, the soft tissue has been sutured. We waited for the healing, and two months after, we started to take the digital impression. Digital impression that always needs to follow the same protocol. So we need to know, and we need to have from the implant company that we are using the scan body, which is working well. And how can we determine that the scan body is working well? First of all, it needs to be easy to scan and to position. And you see that we have a carrier that is helping you to place the scan body in the right position. Second, it has to be in a material which doesn't reflect too much, because the light of the scanner might have the scanner due to his light, might have some problem with the translucent materials, and so they created a material which is not reflecting too much the light. And plus, they kept it versatile, at least at the beginning. So we were like working completely digital, but there were some other also doctors that are working still with the traditional impression. And so these 3D touch scan body can be used both for the traditional impression, like open impression tray, and also as a scan body. So that's another important piece of the puzzle if you want to add it into your clinical portfolio. And here you see how a scan body is made. We have in the top area, the scan region, which is the region that we should know and we must detect correctly, because it is the area where all the information, the relevant information, such as the orientation and the angulation of an implant are. Then we have a body, which helps us to create the best fit. And I'm going to show you how to do the best fit at the CAD, which is another important piece of the steps that we need to know very well. And then we have the base. The base, in our opinion, it's very important that should be in titanium in order to have like a connection which is titanium against titaniums. Here you see, for example, a scan body which has a peak base, and we don't like peak base because it might be accurate at the first 2 or 3 sittings, but after a while being in peak, the accuracy will decrease. So the 3D touch best scan, but the 3D touch scan body from TRI works very well also for this kind of reason that I explained to you. Here we have the very first CAD elaboration that together with our lab technician, Pier Francesco Golfarelli, which is helping us and TRI in developing and always updating the libraries of the scan bodies and of the CAD of the milling strategies. This was his first CAD elaboration. You see the nice connection typical of the TRI. You see here that we have the prosthetic volume. You see everything is under control, the volumes, all the parameters. And another aspect that is very important. We have different screws depending on the material. Also, this is another important aspect. We have everything is related to the screws. So the screw is playing a pivotal role. And I was skeptical at the beginning, but I can tell you that after 3 years of like working with this solution, we just had one unscrewing in one case. So once again, I was skeptical, but right now I can reassure you about the fact that after 3 years, only one unscrewing on a patient which was wearing a provisional crown. So absolutely, the screw is the key factor, but the screw is very well designed, is very well planned, and it gives us consistency over time. And here you see that was the very first PMMA provisional restoration produced in our clinic for this patient, that you see that everything was very nice. The soft tissue is the quality of the soft tissue is nice. The provisional restoration emergence profile is nice. The stability of the implants is nice, and you can see here at 3 years or 2 years and a half, the follow-up where everything is stable. We had no problem of the cementation. Look at the quality of the soft tissue, which is one of the things that I want to highlight the most today in a patient which was not so great in oral hygiene. So it's very important for me to share our experience over time, because it's always nice to share one nice case, but you don't know when this case has been done. This is the very first case with a bone level matrix implant that was done, and this is the 2 years follow-up pictures. Another case in where we push a little bit more the envelope, immediate implant in a fresh extraction socket. You see here the extraction was done, trying to be as less invasive as possible on the soft tissue. The implant was placed slightly palatal, and then we waited for the healing. We didn't load immediately the implant. Here you see a few of the snapshot of the implant insertion and also of the guided bone regeneration procedure that was done. Back then, we had like a provisional restoration that was holding on with the pontic site in the where was the implant site. So we didn't load immediately the implant. We just had this provisional restoration with the cantilever on the fourth premolar, and we waited for the healing. We waited for the healing, and you see that we were able to then do what? To detect the final impression. When you want to detect the final impression, everything that you need to know is that first of all, you need to have a scan protocol and a scan strategy that works well in your end. And here is listed the series and also the same the numbers of the scans that we need to do. So the upper arch with the provisional in place, the lower arch without the scan body, the bite registration, the scan body scan, and the let me go back, and the high resolution scan body scan. In this case, we use the iTero, and you see the quality of the scan that we were able to detect, and also the quality of the soft tissue around the implant and around the natural dentition. Everything was sent to Pier Francesco. Once again, this is one of the snapshot of the digital impression. Here we have like the CAD elaboration, the provisional restoration emergence profile, and here once again the typical TRI connection, the matrix connection. Look, the quality, great picture also shown by Olga about the quality that you have if you are working with the proper milling strategy, which is pivotal. So really need to bond with your lab technician if you want to work with this kind of implant, because the CAD software and the milling strategies are pivotal, and that's the reason why TRI is creating and created already a worldwide patented technical chain in where you can send the case, and there is a list of dental technicians which are certified to work with this workflow, because once again, it's not just the intraoral scanning, but it's also the way of your lab technician is doing his job in the lab. So it's not that if the crown is not fitting is because of the implant, the scan body, the digital impression, but probably because there has been a problem also in the milling phase or in the cam phase. So we need to be I want to be very clear on this. Work with the TRI certified lab technician in order to avoid any mistakes and to obtain this kind of nice crown with this smooth and polished TRI connection. This is the quality of the soft tissue. We unscrewed the case, let's say a few months ago, and I took this picture because I wanted to show the quality of the soft tissue below and around the implant. And here we have the final crown in position, the final two crowns in position, and the stability of the buccal palatal surface, which is another important aspect that we need to evaluate for the final aesthetic outcome of this case. So we can list down a few benefits that the TRI immediately brought into our clinic. We improved the aesthetic. We improved the quality of the restoration. Why we improved the aesthetic? Because we were able also to have like a better emergence profile, not inflamed. It was a simple procedure that we were doing. We were placing the implant, we no need to T-base, no need to cement in our end or in our lab technician end the T-base with the crown, And so we were saving time and we were saving materials. And so this from the very beginning were all the advantages that the matrix concept brought into our clinic. Then what? Let's move forward. I want to talk about my favorite implant of the matrix, the tissue level, because the tissue level experience for us has been great. First of all, look how nice it looks. I really like the shape of this 1.8 pink color, and I think it has been like developed on purpose, like to enhance the soft tissue and to enhance then the peri-implant mucosal appearance. So our tissue level experience, I want to present it to you in a periodontal patient, so with high perio risk profile patient, in where we had like this situation to start with. We had this molar, this second molar that needs, that unfortunately is going to lose one root. So we're going to remove the mesio, the distal vestibular root, removing it, so creating a nice shape of the root with the root resection, prepping the second premolar, and then placing a flapless tissue level implant in the first premolar position. Here, a magnification of the image that I was just talking to you about. You see the root that has been just removed, the preparation of the root resection, and the second premolar, and here you see the osteotomy for our tissue level matrix implant, which is entering here in the socket. Of course, knowing how to place implant is the base, so we should know where to place it mesiodistally and also apicocoronally. So this implant was placed 3 millimeters below the free gingival margin in order to have like the opportunity to create like a nice emergence profile. And what is nice about this case that in the contralateral side, we did the same thing, but we placed a bone level implant because we wanted to do like in the same patient, the two different matrix experience, the tissue level and the bone level. In this case, we also need to do like osteoresective surgery. Also here was done like a root resection. Implant was placed. We were packed because we had like these bone defects. So some bone particles from osteobiol in this case, and then we suture everything and we waited for the healing. Here you see some of the snapshots, magnification of the bone level implant going into his osteotomy. And here we have the soft tissue healing after 3 months. You see how nice the soft tissue looks around this tissue level matrix implant. For me, is the nicest thing that I'm going to show you today. The soft tissue healing around the tissue level is absolutely great. And I can see that consistently in every single case that we are doing since then. Once again, here we have what? We have our digital impression. We need to finalize this case, so we need to start, if you want to do a digital workflow, with the digital impression. And how does a digital impression, a digital workflow starts? With a digital impression. Look also on the contralateral side, the quality of the soft tissue around. And you see here, I can stop the video because we took like one implant at the time, one scan body at the time. So we placed first this scan body because we wanted to, as we were saying, we were in a beta testing situation. So we wanted to test every single aspect of the workflow. Look at the quality and how was, even if the scan body is tall, because it is not short, we can see that the scan body from 3 implant is a little bit tall. It's easy to detect. It's easy to position, and it's very important to detect, as I was mentioning to you before, the scan region. These two areas in where my lab technician will then merge the different software, the different files in the CAD software. Here we have the digital scan protocol, we have the provisional restoration scan, the scan body scan, and you have like two images. We have the lower abutment scan because we had to do like two single crowns in the lower arch as well. And we have the byte registration. After that, all these files are sent to my lab, and Pier Francesco is doing what? Is doing the best fit. So what is the best fit? This here that you're seeing, and let me go back here, this is the scan body from the library that the TRI is giving to you and is uploading to you to your lab technician while you are start working with the TRI. Here is my digital impression. So what is now Pier Francesco doing is going to find a few dots, few common points in this library in order to merge properly the to do the best fit properly to my digital impression. This is a very important point. It's a very important step that needs to be done very carefully, because this is a quality control of my impression. So in this step, Pier Francesco can tell me, you have done a nice impression, or he can tell me, I think I have some problem with your digital impression. So let's see how is he doing. You see, it's rotating everything, double checking if everything is fine. And you see, he's determining and choosing a few spots in the scan region area. And what is he doing? He's gonna choose them, probably another one here, and he's gonna try to choose the same spot here. 1, 2, and 3. And all of a sudden, the two images are merged one on top of the other. I wanna show you exactly this moment because it's very important. This is the moment in where everything is merged together. You see that we have like the darker purple color, which is the scan body library, which has been merged nicely into the scan body that I have detected in the real life. You might say, probably this is not so easy, but I can tell you this is easy, and it has been made easier for crowns, for bridges, always from the updating and from the evolution that TRI had in these last years, because they created the ScanBridge. The ScanBridge are these little nice piece of plastic that, especially when you're working in bridges or in full arches, are helping you in taking the scan, and you can see here in real life of a full arch in like 30 seconds. So you see how this ScanBridge protocol is helping us in connecting the different scan bodies when it comes to a full arch or when it comes to implant bridges, simplifying our life. And remember, we want to simplify our life. We don't want to make it more complicated. And so this is one of the latest addition of the portfolio that TRI did for us. Moving forward, in the previous case, I want to share with you the CAD design that Pier Francesco is doing. So you see now at the CAD, he has everything under control, and here he has all the algorithm and the mathematics that are giving him the possibility of creating the TRI design. And here is also doing my provisional restoration design. So taking care about the provisional restoration, about the emergence profile, taking care about the design of the look here is very nice. He has all the major variables under his control, and he could and he can utilize his know-how in front of a screen. So that is the reason why, once again, I suggest you to work with your TRI certified lab, especially for the very first cases, in order like to simplify your life, not in order not to have any doubt, in order not to have any pitfalls during this journey that it's very exciting, because everything is smooth, everything works properly. So once again, work with the lab technician which is certified. Here it was also, I wanted to show also the design of the emergence profile, and the design also, let's see if I can see in the root resection, you see here is taking care of also the nice design of the root resection area. So everything under our lab technician control. Here you see few other few other images, and you see always the TRI connection. And this is the CAD image. Next to it, we do have like the CAM production image. And at the very end, in the monolithic material, because these are all monolithics, the lab technician can utilize his own artistic skills to create some nice aesthetical characterization. This is the 2-year, this is the day of the cementation, but I'm gonna show you that we also have like a 2-year follow-up. That's not, of course, the picture of the 2-year follow-up. That's the picture of the day of delivering the case. Everything went in properly. Everything went in smoothly. No problems at all. You see the nice work that Pierfrancesco was able to do in these lateral views. And here we have the 2 years follow-up. You see, everything is stable, and we have like the X-ray story of the case. Initial situation, implant placement, 2 years follow-up, and look once again, the quality of the soft tissue around our implant. Everything is stable, everything looks nice, there is no inflammation, and this is what counts the most for us and for our patient. What I like to share with you is that now we have like the opportunity to basically scan, placing an implant, scan, immediately 3D print a provisional restoration, and within 1 hour, thanks to the collaboration that TRI has with the SprintRay, to offer to our patient a nice 3D printed provisional restoration. And this is a case that I want to share with you. He's a friend of mine that needs to place like these 2 implants. And I told him about this opportunity. He was excited about it. So we placed 2 tissue level implant. We place the implant. You see here the 2 implants, the suturing phase. We always take the scan with the suture in position. We don't just place the implant and then place the scan body, wait for the suture, and without suturing taking the scan. We always suture and then digital impress our patient. Here we do have like the image of our clinical situation, of our digital impression, and immediately we send the image, in this case, to the certified lab in Zurich, if I remember well, to the certified lab in Zurich, and through the ExoCAD CAD protocol they designed in 20 minutes, 30 minutes max. They designed the crowns. They sent us the files, and we placed the files into our SprintRay 3D printers, and we produced the provisional restoration in 47 minutes. Right now, at the recent IDS, SprintRay introduced the Crown Fast kit, which basically in 20 minutes produce provisional restoration with a great quality. So we are even more speeding up the process. And here we have 1 hour after the surgery, let's say 1 hour and 30 minutes after the surgery, the final picture of the day. So in this, I just want to wrap up everything that I told you. We are living a great era. For me, it's a great time to be in being a dentist, because there are so many innovation that are entering in my daily routine. First of all, I have like a great quality implant, because we cannot discuss about the quality about the TRI implant, but I can incorporate this implant into our workflow, increasing the quality of our restoration. And because I want to go back to the very first slide that I showed you today. Here is when a revolution is really a revolution. We need to keep up with the quality of the restoration that we are offering to the patient. We need to save time. We don't need to increase the time. We need to be cost efficient. So we don't need to increase the cost. We need to decrease the cost, maintaining the same level of the quality, and hopefully decreasing the time of working. And also we need to offer something which is long lasting and predictable to our patient. And I can tell you absolutely that the TRI concept, the matrix concept, is exactly following these 4 parameters: increasing the quality, reducing the time, saving cost, and thinking about the patients. So this has been a great pleasure for me, sharing these 55 minutes together. As Olga was telling you, it will be a great pleasure for my brother, that I'm pretty worried, because probably had a complication in the surgery, like Enrico, because he was almost done, but probably had a complication. But I tried to drag him at least to say hi. And it will be a great pleasure for us hosting you in Modena, 17, 18 of November, for this for sure 2 days of fun, because we're going to have a lot of fun and some education. And why it will be a lot of fun? Because Modena, for those of you that doesn't know, is the hometown of the Ferrari. So it's a small, cozy town, and so it's nice to be living in a small, cozy town, which is not New York, because I know everyone, and so I can create like a nice experience for all of you that are coming. We're gonna have like a nice Ferrari experience. We're gonna have dinner in the Ferrari Museum. We are gonna do F1 simulators, and we're gonna do all of this before the course. So no matter what we are showing after, you're gonna have a fun. You're gonna remember the course like a fun course. And Olga and Valentina, like kind enough to give you like a benefit, discounted benefit. Maybe Olga, you can take out, you can discuss more about it, about this after this webinar. But the social program, it will be great. And plus, the good thing is that we are not like online. So if my brother is placing some implants, you can see him placing implants, because I feel sorry that you didn't see him today, but he's there placing implants. So next time you're here, so you see him placing implant and doing a real touch and feel experience with us. So you can go.
Thank you, Andrea. You already talked now about this course. I wanted to announce this as well. And before you leaving, you see here on Andrea's slide the benefit for all of you who are taking live here place on this webinar, have the chance to get a 20% discount on the early bird price, actually, until the end of this week. I think this is April 23rd. I'm in Australia. I'm confused with the date in a little bit, but it is until end of this week. You can have a 20% discount on our early bird ticket price. So therefore, I would like you to use this code, which is here, webinar 20. which you have to use when you would want to be a part of this nice happening in Modena. Thank you, Andrea. We have
I think there are a few questions as well. I think there are a
exactly,
few
there's
questions as
questions,
well.
exactly. There is questions, and I would like, because we are a little bit behind the schedule, I would like pass you some questions, because one question I think is really nice. It's from Mohammed, and he is asking, how will this affect osseointegration, which is done for the abutment to adapt in the alveolar bone? And I already wrote. I already wrote something, but I think I please answer you, Andrea. What would you say to this osseointegration part after 2 years or prosthetic results?
Well, for sure. I mean, of course, we need long-lasting. We need longer data, but for sure, if you think about it, if we have like a gap or if we have like cement, this can decrease the not the osseointegration, but it can decrease like the healthy status of the peri-implant mucosa and the peri-implant bone. So you might experience some peri-implant bone loss. The osseointegration, it doesn't it is affected in such way. So we might get like possible complication down the road. If we are reducing the interfaces, so we are removing the tie bases, we don't have any gaps anymore. And what is very important is that I tried to point this out, the screw should be as it is, stable, because then if you start to have like some unscrewing, then it's the same concept. We create, the bacterial gets in, so we don't have to have any unscrewing. And I can tell you, in 3 years, we had only one unscrewing. This
in
is
the temporary.
In the temporary. So what I'm telling you, this seems to be extremely promising. And
I can also add from our side maybe to this question. We have this, and actually I want to tell you as well, Andrea, we call this implant which is behind here not anymore tissue level. We call it a multi-level implant due to this concave design and anodized surfaces in this area. This is a game changer also in the osseointegration time. We have just published a new study of one of our heavy users since many years in the tree system, and he compared our tissue level implant with the Octa connection with the new multi-level matrix implant in 50 different patients, and he has the osseointegration way followed in, and compared this with this implant and our classical tissue level implant. And it's significantly better. And I am 100% sure that has something to do with the anodized surface plus no cementation, because cementation, this is an inflammation time. This is bacterities already very close to the bone, which you cement onto it. And this is not existing here with polished zirconia. And that's why we have here, and we see that now over 2.5 years prosthetic follow-ups, that we have a significant better osseointegration or stable bone over 2.5 years. That was this answer for this question. Now we have to be a little bit quicker. Do you expire any preload loss in your cases? I think we answered that already.
I have to, exactly, no, absolutely not. I mean, so far it has been very, very successful, our experience with the TRI.
And then the next question from Anna, what we will do when we need angulated abutments? I think I can explain this very quickly. And this is a part of, and that's something I cannot share now anymore, but we have a so-called certification program for dentists and for dental technician. And in case you are a dental technician or a dentist, Anna, it is great to go online. You will find online on the TRI website, you will find the explanation how everything works here. I can tell you this connection, the matrix is ready for the future, and all the milling machines are able to mill angulated screw channel. That means you can do a full arch restoration even with 50 degrees angulated implants. You can screw retain with a rotational free full arch. You can screw retain that directly without using an abutment, and to to put the screw channel into the not aesthetic zone, you can even mill an angulated screw channel in this part. That's a part of the digital certification, of the dental technician's certification, to be able to angulate the screw channel in any direction. So it's super aesthetic and there's no need for any abutment anymore. We don't sell any abutment for this system so far. One last question, and then I think it's okay from the timing. And
I think are nice. I think what I have tissue level part of the implant is a 1.8, right? Always
yes.
1.8 millimeter. And what is your experience with placement of matrix tissue level implant and bone level implants? At the beginning, we were placing both. If I have to say, lately, we do love so much the tissue level that we only place tissue level, because we think that, and we have experience that has been like so nice, so successful. We didn't have any issue, especially when we are placing some flapless implant. We go always for the tissue level. Immediate implant, we go for the tissue level. We always use tissue level implant most of the time right now, less bone level. And I think that's also the trend that you guys have, Holger. Confirm me if I'm wrong.
Absolutely. Yeah, because it's called multi-level, and the concave design, as you see it on the picture of me on the side, allows you to go with the anodized surface into under the bone level, not the prosthetic part, because this is a way, and we know the biologic widths, and that's why with this anodized surface we have that great results over this 2.5 years osseointegration cases. So guys, I think we are already over the
one important question from Gianpaolo Gennari is asking which kind of 3D milling machine could be used to mill the zirconia, which kind of CAM software you need to mill precisely the connection with the implants. It is a long answer, but I think you can use basically all the milling machine that you want. But if you want to send me a private message on our Instagram, I can put you in contact with Pierfrancesco Golfarelli, which can tell you all the details of it.
Okay, so that was our question and answer round, and just give me 2 seconds of your time more, because I really would like to quickly share with you again on the 17th and 18th of November. We have this beautiful course. Here is the code you have to use, webinar 20, to get a 20% lower price of the early bird ticket for the early bird prices. And there's another course on the 2nd and 3rd of June in Portugal. This is for dental technician. Maybe there's dental technicians, they want to know everything how to mill this perfect connection, should come to beautiful Lisbon on the 20th and 3rd of June this month, in 2 months already, and have a dental technician experience how this matrix will be milled perfectly. And now at last, the last slide here, I just want to please you, and also that the cases inside of the Agninis, which you just showed, and there's a lot of more cases with 2.5 year follow-ups. Just do a screenshot of this QR code and you will get our volume 3 case book, because this is really, we saw this now in the questions. You can see there all the follow-ups with the osseointegration of the last 3 years of matrix placements, and then 2.5 year prosthetic follow-ups. Please follow there, and we will always update this case book every half a year. With new cases and also with existing cases, sorry. Okay, so I would like to say thank you, Andrea. Thank you to Italy from Australia. Very great that this digital journey is working so well. If there is more questions, you see the email address and the website address from TRI. You can ask always further questions through this, and go on the website. You will see everything very, very detailed, what the matrix can do. Okay, thank you, Andrea. Say hello to your brother, and hopefully the patient is still alive.
I was just trying to also on the schedule, because there should have been a problem.
Okay, so thank you very much. Bye bye. Bye bye. Have a good time. Bye bye.
Bye bye.